I'm Malika Shekhar, a haematologist in London, UK. Welcome to my podcast series called The Bitter Pill, which looks at lessons that we doctors may learn from history. This podcast is called Shared Decision Making. The golden age of haemophilia in the 1970s saw the complete transformation of patients' lives by the use of factor concentrate. This time period also gave patients greater choice and more control of their own treatment. Treatment could be based not just on facts, but also on value placed on quality of life, so a sense of normalcy. But these are societal values, and so practice differed across countries. But in fact, the more compelling influence was economic. How robust was the blood supply chain, and what was the capacity to produce or purchase concentrates? The terms of shared care alliance therefore diverged along economic lines. Shared decision-making is now described as a situation where health professionals and patients work together. Within our health systems, we share our clinical decisions most importantly with our patients. But we also have other access, important ones. We share care between hospitals, between professional bodies, as members of professional interest groups, even the pharmaceutical industry. These are ways by which we can refine decisions in our patients' best interest or contribute to collaborative learning. How did the iatrogenic events of 1980s affect the golden alliance of shared values of the 1970s? This episode will address shared access of care and what happened to them in that decade. We begin with patients and then touch upon some of the other aspects. The extracts are drawn from the YouTube recordings of evidence given under oath at the UK Infected Blood Inquiry. Questioning the doctors are Counsel Jenny Richards and the chair of the inquiry, Sir Brian Langstaff. A panel of medical ethicists also provide their insight. Whose decision is it? We have Dr. Hayes' views on the use of cryoprecipitate. Dr. Charles Hayes started in May 1987 as consultant haematologist in Liverpool. One of the choices that clinicians faced in the early 80s was to reduce treatment intensity from factor concentrates to cryo. It was generally accepted that cryoprecipitate was less risky regarding HIV, but clinically it was suboptimal and more demanding to administer. Imagine you drawing and injecting 10 bags of gloopy cryoprecipitate after thawing them to nip a bleed in the bud. This section deals with the question of why not switch to cryoprecipitate, at least temporarily.
Do you accept that the question of whether to take the risk of having less than ideal treatment was a decision for the patient to take rather than for the physician to take for the patient?
Let us go back a step on this particular question of who decides the level of treatment.
What's the evidential basis for your assertion that changing to cryoprecipitate in 1983 for a year or 18 months would have dramatically increased the risk of death as a result of hemorrhage?
For that period of time, they would have been more at risk of dying from hemorrhage. Okay, yes, it's a limited period of time, and that would reduce the danger. But for most patients, it would have meant reverting to hospital-based treatment. Now, this was one of the great advantages of concentrate because we knew that with haemophilic bleeding, the earlier you treated it, the less damage was done. And so when the patients, if they develop a headache, which may just be a headache or it could be the early signs of an intracranial bleed, a delay can be really life-threatening. So if somebody with haemophilia phones up and says, I've got this headache and it won't go away, you'd say to them, give yourself some factor VIII and come in to the hospital. But they would have treatment before they left their house. And that could be a matter of life and death.
On this hypothetical scenario, the delay that you're describing could have been dramatically reduced by the provision of cryoprecipitate as a home therapy.
I think in most centres they considered that it was not a suitable product for home therapy for logistic reasons.
Do you accept or agree that the question of whether to take that risk of possibly delayed treatment in the event of a headache, or to take the risk of having less than ideal treatment for other bleeds and possible risks of joint damage, was a decision for the patient to take rather than for the physician to take for the patient?
Well, that's an interesting philosophical question, because the big problem is that these decisions were being made on the basis of very little information. And, even the guidelines that came out were not as evidence-based as we like our guidelines to be, because they were based on opinion. And the opinion was very poorly informed because there were so many reasonable questions about AIDS and subsequently HIV that just were not known. A lot became clearer once a test became available.
This extract discusses the concern about downscaling to cryo during the period of maximal uncertainty. The balance of risk regards bleeding versus AIDS, as Dr. Hay points out, is a fine one. Doctors knew how best to prevent bleeds. There was less evidence for preventing AIDS. But the question he's asked is about patient choice. Who chooses the level of treatment, and how does that take shape? In the discussion that we just heard, two threads emerge. Was the decision about cryoprecipitate paternalistic? What did their guidelines advocate? Let's look at the vexed issue of paternalism. We hear Dr. Colvin's views.
Others have used the term paternalistic to describe, in some respects at least, the approach to clinical decision-making in earlier decades. Do you think that is a fair description of clinical decision-making in this context in the 70s and 80s for haemophilia clinicians?
I think it is, and I think it's also very interesting to reflect on what it means, because I think that the correct putting of the patient first does create a burden on the patient which can be difficult for the patient to bear. So if you take paternalism at one end and total patient choice at the other end, and of course I completely agree with the idea of patient choice and autonomy, when you're ill yourself, you may take a different view, in the sense that, referring to my arthroscopy a while back, I wasn't, I think, given a really clear choice between, shall we say, physiotherapy, arthroscopy and knee replacement. My surgeon said, you need an arthroscopy. And I said, OK, you're the doctor, let's get on with it. Now, maybe orthopaedic surgeons are particularly paternalistic. I hope I don't abuse orthopaedic surgeons by making such a remark. But it is the case that many of us, including myself, quite appreciate that the doctor is the expert, and we want to be told what the doctor thinks the best treatment is. But, and I think this is terribly important, we need to give patients the best information and the choice of what we do next. And we don't always get that right. Sometimes we don't. And that, of course, is sadly a fact of life. But I do believe that in the past it was more paternalistic. But the process of paternalism wasn't always completely disadvantageous, because it took the responsibility of what happened next away from the unfortunate patient.
So paternalism has its benefits, but patient choice and autonomy are sacrosanct. Here is a discussion by the experts of the inquiry's ethics panel. Professor Julian Savulescu, Ian Kerridge and Bobby Farcides are professors of clinical and biomedical ethics. Let's listen to their discussion about paternalism.
There's two versions of paternalism. There's soft and hard paternalism. Strong or hard paternalism is where the patient is competent and able to make their own decision, but the doctor makes the decision in their best interests without involving them in the decision or even overriding their desires. Soft paternalism is where the patient has some deficiency in their decision-making capacity, And in the presence of that, the doctor does what they believe is in the best interest of the patient. Now, sometimes what was actually operating was either hard or soft paternalism. Sometimes doctors believed the patient couldn't because of their emotional state or their ability to accommodate information, truly make a properly autonomous decision for themselves. That was soft paternalism. Or sometimes they just didn't bother or actually overrode what the patient wanted. So there can be two kinds of paternalism operating.
I think it's also worth acknowledging that there are accounts of autonomy that would allow you to delegate authority to doctors and actually give them permission or request that they behaved in ways that from the outside might look quite paternalistic. But the difference is that the patient has said, I don't have the emotional reserves to deal with this right now, or I'm finding it absolutely impossible to make sense of these forms of information. I really would value you advising me quite strongly on what to do for the best. So modern accounts of autonomy don't necessarily mean complete independence or sovereignty over your actions, but the sense comes that you give the doctor the permission and the right to be involved to that degree, rather than it being any form of assumption that historically this is the way that things have been done, or simply that the level of expertise held on the part of the doctor entitles them in some way to do that. So I think paternalism, again, it's a complex issue, and it's one that the more you talk about it, the more the heat is taken out of it to some extent, I think. And one must always remember that idea that it is motivated by beneficence, not by a wish to control or overrule.
Well, I think soft paternalism might be capable of being justified, but I think hard paternalism of overriding a competent person's wish, I think, is extremely difficult to justify.
I'm not talking about justification, I'm talking about motivation.
Can I add just something? I think it is a useful distinction, but I think you need a tripartite distinction. You need to distinguish between beneficent paternalism, even if it's misplaced. You need to identify lazy or other, sometimes called vicious practices which just represent a flaw in the position. And the third category, which I've alluded to, is people operating as best they can within a system which just doesn't allow them to do the right thing. And I think that some of the problems may be the result of systemic problems. So there's a difference between not having enough time to engage in a difficult discussion and not wanting to because it's difficult and you'd rather do something else. And I don't know of any systematic research on this, but my strong suspicion is there's a mixture of all three in practice, and just how much of it is vicious and how much of it is the result of a very flawed system is difficult to say.
I think that's hugely helpful, Julian, and I think it also helps us to understand how people might look back and reflect upon what happened in some cases with personal regret, with some acknowledging belatedly that the system had not allowed them to do what they would wish to do. So I think that's that trio of examples is really helpful.
So if we applied these comments to Dr. Hayes' comment on cryo, choosing the level of intensity of treatment was motivated by beneficence, based on prior discussions and assumptions of what they had thought their patients wanted. Underpinning that, the belief that factor concentrate was better. There were many resource constraints, but then there was this long-term relationship with the patients that was strong, they thought. There were shared values. The decision was joined. It was not a binary choice, in their view. Let us hear Professor Kerridge, a haematologist and ethicist from Sydney, on our assumptions about our patients.
The other thing, so Brian, and you mentioned the clinician making an assumption about what the patient would want because of how well they know that patient. I mean, Bobby's an empirical ethicist, but there's a huge amount of literature that suggests that clinicians are rubbish at predicting, or knowing full well what patients want by genuine and deep knowledge of their values. I mean, I might say other health professionals are also rubbish, sometimes slightly less, but doctors are particularly bad at it. But even patients' loved ones are also particularly bad at knowing full well what someone would want. So all of this provides empirical support for the idea that you have to have that conversation.
So we need that renewed conversation before deciding a patient-centred decision.
In today's world, quite properly, the patient is at the centre of care. Now, whether 30, 40, 50 years ago we fully understood that the patient was at the centre of care in the way we should have done, I think is less clear. I still interview for admission to medical school, and one of the questions is, in a particular scenario, who's the most important person in this scenario? And the correct answer for the student who wants to be a doctor is it's the patient.
Was that not the thinking in the first half of the 1980s, that the patient was the most important person in the scenario?
I'm not saying it wasn't. I'm saying that attitudes, I think, have developed over the last 50 years in a way that patients are now more clearly at the centre than perhaps they were in the earlier part of the middle of the last century.
The principles of patient-centred care that we now practice is a two-way dialogue. We advise and the patient chooses. But our advice, especially in the public sector, example NHS, is based on guidelines and resources. This is now referred to as realistic medicine, that a doctor should recommend steps that add value and minimize waste, a personalised decision framed by the realities of the service. How does this work across the patient's journey? Because most patients have many touch points in their medical journey. Shared care between systems.
We drew people in. We found all sorts of people with haemophilia who'd not been looked after. I mean, there was one patient who, I suppose in his 60s when I first met him, who literally had knees that were in fixed flexion. All he could really do was to lie in bed, read the Times and watch the cricket on television. That was his life. When things happen, you need to know where to go, what to do. And so it's no good having an ivory tower, if you like, in no towers in Whitechapel or Ivory, but no point going to an ivory tower in Whitechapel. When anything happens and you have to go to, say, Southend, they don't know who you are. So the whole idea was shared care, things that required critical mass or expertise. We tried to deal with at the London, or at the Royal Free, but things that were every day were happily dealt with at a place like Southend or Harlow. And I was determined that those associate centres should not lose touch with my patients. I mean, there were a number of patients of mine who could have been infected elsewhere. Patients understandably wanted to know where they'd been infected. And yet for me, it was much more important to look after my patients than to worry about exactly where they'd been infected, because some of them had been infected outside my care. But I didn't care for them any less because they'd been infected away from my care. I can give an example of something that happened which is important. So a patient comes to London for educational and professional purposes. He's a young man who's got relatively mild haemophilia. He has had an injury, a sports injury, and he's treated and develops HIV infection. He is understandably deeply upset by that. And I spend many, many, many hours with him and with my nursing staff trying to manage his distress and his clinical circumstances. Some years later, he becomes mortally ill, and my haemophilia nurse and I are told about this one morning, and we drive over 100 miles to try to reach him before his death. And he's unfortunately passed away when we arrived there. I tell this story really to illustrate the terrible nature of what was happening. And I tell it particularly to describe his resentment at the fact that he had been infected in a way which he thought was completely unnecessary. Now, I'm not in a position to judge whether his infection was unnecessary or not. I wasn't there at the time when he was treated and infected. But I do know that he deeply resented what had happened. And I can understand that. But the point that I was making before was that I wasn't sure that that deep resentment necessarily helped him to manage his situation. And that my job was to do my best to help somebody in a position which was, of course, intolerable and terrible, and which I and my nursing staff spent many, many hours trying to resolve. And it cut to the heart of what we were trying to do.
We share the care of all our patients. All points of view ideally should come together in the interest of the patient. In reality, as Dr. Colvin states, we think of them as my patient, but feel the need to ensure that they can access other sources of help. That's to say that they're not lost to the system as the 60-year-old man watching cricket was. Dr. Colvin also describes how the young student felt, a deep resentment of his situation, and how his team tried to address this. There is an element of helplessness and resentment by the patient. There's also the powerlessness of the doctor when actions happen outside his sphere of influence and he had nothing remedial to offer. These situations can be described by the phrases moral distress leading to moral injury. Moral distress and injury are phrases originated in moral philosophy, but used in settings of war. They've been deployed to describe the situation of both patients and staff during the COVID pandemic. They're relevant in the description that Dr. Colvin has just made. The young man has a moral expectation of safe treatment. That didn't transpire. Furthermore, in his eyes, there was no true reparative step, a cure for AIDS. In some situations, patients had no choice other than to stay with the doctor under whose care the infection initially occurred. Here is Prof. Ludlam from Edinburgh.
As a matter of fact, a patient with a lifelong bleeding disorder living in a particular area is not really going to have much of an alternative, are they, other than to carry on being treated by the centre at which they were infected, potentially under the directorship of the consultant at the time?
You're absolutely right. It's the Hobson's choice. I was the only person with the expertise in southeast Scotland at that time. Subsequently, there were situations in which I tried to recruit another consultant to help, and I couldn't find anyone who was prepared to assist me. It's also at a time in the decade after this that it became very difficult to recruit into the specialty because of the difficulties that had arisen in relation to all of this.
The patient continued at the site. No one else is available. In fact, recruitment in haemophilia was difficult the world over for the next decade. The therapeutic relationship had to survive all this, and across the world, this relationship, which was cherished in haemophilia, was reappraised in light of new rules and governance and greater agency of patients. So relationships which were previously based on cooperation and complementarity changed to those based on negotiation on equal footing. The shared care of the dead, their tissue.
What were the problems with the coroner and with the undertaker that led to not usually including the term on the death certificate?
So this was an issue that caused very great distress. AIDS was not a notifiable disorder. However, as a doctor, I was obliged to inform a coroner of any death that was not natural. And of course it was not natural for a person with haemophilia to die as a result of HIV. I did it very reluctantly. The coroner, in response, felt obliged to hold an inquest. There was very intense correspondence along the lines of, this is going to cause the family, who are already greatly distressed, even more distress, and if the purpose of an inquest is to establish the medical cause of death, that is already known. We know why this patient died. They had haemophilia, they were given contaminated blood, and they died of AIDS. So why do you have to hold an inquest? The coroner would not be moved. To make a bad situation even worse, that meant that at the inquest, I was commanded to attend, describe the cause of death, which would then be reported in the local press. On one occasion, "Bad blood kills boy" on the front page, together with the name and address of the child. So this was, well, you'll gather, it was a very, very distressing episode, and it couldn't, every time we had a death, we had to go through this exercise. The problem with undertakers was you'd inform them about the HIV infection, which I think you had to do, but they would turn up wearing spacesuits, which was inappropriate.
We listened to Dr. Mark Winter, a haematologist, talk about the coroner's autopsy. The stigma and the distress following the death of this boy due to HIV was terrible, and Dr. Winter's experience highlights the role of the doctor in continuing to address the patient's best interest after death. The technique of verbal autopsy was developed in low and middle income countries in the early 70s. It was a practical alternative to physical autopsy. It was driven by circumstances, but it did diminish the distress generated by coroner's autopsies. Standards for verbal autopsy are defined by WHO, and this technique was used in COVID-19 deaths in many parts of the world. What about learning from dead tissue? When VCJD came into the picture, there was immediately a fear that this was AIDS all over again. There was a need to understand how this infection, with its long latency, might affect haemophilia patients dependent on large volume blood product support. Standard autopsy were not options because special stains on specific tissues were required.
Just one issue I wanted to ask you about a VCJD surveillance study. So it refers to studies relating to VCJD, haemophilia and implicated products, material obtained either from postmortems that have already taken place or from postmortems that may take place prospectively. So it would appear that in relation to the retrospective study of postmortem material and indeed biopsy material from deceased patients, there was no intention to notify relatives or seek their agreement. Is that your understanding from this material?
That's my understanding. I know that they took this question to the ethical committee and also with the CJD unit in Edinburgh. And it was the ethical committee's opinion that we didn't need to.
Do you know the extent to which centres hold post-mortem material that would have been covered by this study?
Well, that's part of the problem because I don't think that they do. You know, after the Alder Hay scandal, retention of material was dramatically reduced. The Human Tissue Act has a lot to say about the retention of material, and so retrospectively there is little or nothing available.
But societal distress about retained tissues in 1999 had led to tight restrictions on use of tissues. Furthermore, autopsy rates, even limited autopsies, have declined dramatically because we can often answer the question, why did the patient die? But the question of what can the death tell us? For example, with endothelial pathology in COVID-19 infections, was understood only after autopsies. How does our shared identity as haematologists work? Here is Dr. Colvin's perspective of the haematologist's mindset.
Patient's consent may in certain circumstances be given implicitly, for example, by agreement to provide a specimen of blood for multiple analysis. In other circumstances, it needs to be given explicitly, but that it's particularly important in the case of testing for HIV infection.
I don't believe that it was ever the case that there was any other particular investigation which absolutely required specific patient consent. This was really the first time in 88 that this had been suggested. I referred earlier to the role of the haematologist, that is, being both a physician and a pathologist. So if I was sent a patient for investigation, then I would decide which investigations to perform. And when I got the results of those investigations in my laboratory, I would then choose what further investigations were to be performed to solve the problem. Now, all that has a continual flow of information, of course, and it's my responsibility to choose the right tests in the right circumstances. However, there may be another instance where that chain of flow has been broken, and then it will be necessary to go back to the patient to ask for consent to continue a separate investigation that now became apparent. But the reality was, I think this was partly the mindset of haematologists, that we felt that we were physicians who were also pathologists who had the task of solving problems. And we believed, perhaps incorrectly, that we did have the kind of consent that we required to undertake these investigations to solve an urgent problem. Now, I can see there may be those who disagree with that view, but that was the view I think that we had.
As haematologists, we request reflex testing. Anemia, low MCV, normal ferritin, we would ask for hemoglobinopathy studies. It's smart use of material to give the patient an answer. How to solve a problem using the material that we already have. There is the important matter of consent, but also the responsibility to use a sample of blood to obtain as many answers as possible. In 1984, when evidence was accumulating, doctors made choices on the basis of peer opinion, your own mentor's opinion, and recommendations by the professional body of haemophilia doctors in the UK. This was the UKHCDO. Let's hear 3 views of how peers and experts influenced decisions.
This is voiced as general recommendations, falls short of being an instruction or firm advice. It's to some extent leaving it to clinical judgment. Would you agree?
In a sense, the 1980s, professional societies of like-minded physicians like hepatologists or dermatologists, they wouldn't be issuing guidelines. That didn't really start to even be thought about to the 1990s. But the reference centre directors, through their activities and the information they provided at the annual general meeting, were influencing how haemophilia care was provided. If you like, it was an informal mechanism, part of developing people's knowledge. It was UKHCDO's interest in promoting good haemophilia care that led to the full investigation of the Bournemouth hepatitis outbreak and the tremendous detailed epidemiology. That was unique in the world. That nothing like that had ever been done before. Out of that became an acute awareness of the vulnerability of certain groups of patients to hepatitis.
The role of UKHCDO was viewed with envy by many abroad. Here was an umbrella group that shaped opinions. As evidence unfolded for transfusion-transmitted AIDS, there was immense relief, hard evidence. But evidence is not independent of the society it's generated. Its interpreters, that's you, and the affected, your patient. And so for a period of time, in 83 and 84, practice varied a lot. In the UK, the UKHCDO influenced practice. There were experts. It was informal, a nudge technique. Guidelines and protocols didn't exist.
The famous phrase, clinical freedom, the ability of a doctor to look at some guidelines and say, I'm going to do something totally opposite to that because I have clinical freedom, a very dangerous concept. So this was, this moved from being a guidance, which is advisory, over the course of the next 30 years to being essentially a strongly recommended protocol which was produced by experts and you were expected to follow it. And if you didn't follow it, then that might be a problem.
Some doctors acted with clinical freedom. This was more common in countries lacking a national organisation, but on the whole, in UK, there was tacit acceptance to stick with the soft recommendations of the UK HCDO.
Did you understand it to be the position of UK HCDO that smaller centres should fall in line with UK HCDO's recommendations?
Definitely. I mean, I don't know whether there were any real dissenting voices. There may have been warning voices, but I don't think actually anybody dissented from the general view. This was informed by the structure of medical negligence thinking at the time, which was based on the Bolam test. If you had gone away from their advice, you would have become vulnerable to claims of negligence. So I can understand why he was emphasising that we didn't have the power as a small centre to go off on our own track. So those doctors were in many ways admirable doctors, far more distinguished clinical scientists than I ever was. I would feel embarrassed confronting them with it, but the fact is, I think that they held the line to the point where it almost became like denial into 1983. I think to continue to propose that there was no conclusive evidence that AIDS was caused by an infectious agent was simply, in retrospect, of course, a denial problem. But hindsight bias is not something any of us can avoid. In fact, it's like an inherent part of the human brain. Doctors are usually accused of over-exaggerating dangers rather than the reverse. I think that's probably our role. The precautionary principle did not, to my knowledge, exist then, certainly not in medical practice or common parlance. The idea that you would actually take action in respect to perceived dangers, even if those perceived dangers were relatively remote or not defined. So the approach to VCJD, for example, from the outset has been based on the precautionary principle that no matter what inconvenience, problems it may cause in everyday life, you have to proceed on the assumption that certain people are going to be transmitters of the disease. But that concept of precautionary principle, it may have been published by philosophers, but it had not yet appeared in medical practice, like many other subsequent developments like the concepts of clinical governance, etc. Every clinician is a creature of their generation, so I may well have attitudes that future generations will find equally hidebound or non-responsive, but that's all.
There was little dissent. You could get into trouble with clinical freedom. The Bolam principle meant it was safer to stay with what a reasonable doctor would do. There was also a collective thinking, including denial. Experts faced with incomplete scientific data adhered to existing paradigms rather than embrace new and unproven ideas to make critical decisions. That pattern of responses has occurred in other major epidemics since. Many things have changed. By early 2000, the legal principle framing negligence shifted from Bolam to Montgomery, a decision based on what a reasonable patient would want. That is, a patient-centred decision. Of course, in countries like USA and Australia, this approach to decisions and negligence was the case a decade or more prior to UK. Precautionary principle and duty of candour are core values now. But not all has changed. In current practice, for example, despite the existence of guidelines, we often rely on more responsive systems. So one example is Mind Lines, where we base our actions on views and practices of our immediate colleagues rather than on published evidence. Another example is our reliance on opinion leaders in how we frame choices to our patients. What about involving stakeholders in constructing policy? Many gatherings and meetings about blood donation in early 80s did not include the haemophilia group as stakeholders. Stakeholder representations are not always what they ought to be even now. we've witnessed the confused handling of masking in COVID-19. Stakeholders didn't agree with the uncertain science. They were unwilling to own the issue. How about paternalism, which is where we started? I leave you with the reflections of Emma Cave.
I've also mentioned a couple of times the Cumberledge Review, where there was avoidable harm to patients because they weren't listened to, and consent is a theme that runs through that report as well. And then we very recently have the interim report from the Ockenden Review, and that's a review about caesarean section rates and trying to keep those as low as possible, and failing to listen to women who actually wanted another course of treatment, and the result has been deaths and injury to babies and to women.
It would appear from those reports that there remains in 2021 a problem of doctors still not placing patients first.
I think it's true that there are examples of doctors not placing patients first, but I think we also need to be clear that it's some doctors. In fact, it's some healthcare professionals, and there's also problems with the system as a whole that leads to some of these issues.
I don't know exactly the figure, but the UK spends about 8.5% GDP on healthcare. Most other advanced European countries spend 11 or 12%. And at the end of the day, it's just been a healthcare system run on a shoestring, and you get what you pay for, really. And these are really deep problems.
In summary, shared decision-making is the backbone of patient-centred care. Although this existed in some form in the 70s, the dramatic turn of events in the 80s made huge dents in this fabric. How we practice medicine is transformed. Precautionary principle, duty of candour, consent, Montgomery. But individual and collective instances of poor practice persist. Future generations might view us with concern. Thank you for listening to this episode.